So I'd like to discuss the use of long-acting antiretrovirals today. These are my disclosures. I'd first like to start off with the recent study HBTN 083. This was a study looking at comparing an injectable integrase, cabotegravir, to FTC Truvada. And you can see here there are about 4,600 people randomized to get to about 2,200 in each arm. About 4,600 cisgender MSGM and transgender women who have sex with men were included in the analysis. The key piece here is that they looked at populations that were at risk. So the average age was 28, about 2/3 of them were under the age of 30, 40% under the age of 25, and 12% transgender women. And half of them were African American and Black. And so one of the hallmarks of this study was it really looked to evaluate the use of cabotegravir in the population most at risk. And what you can see here is that there was a significant difference. In fact, there was such a significant difference that it was statistically significant, and the study had to be discontinued because there was such a difference. And the difference favored the cabotegravir arm. So the use of injectables favored the use of daily tenofovir FTC by a significant difference. There were some interesting things about that study. We know that there were differences in adherence that drove that, which I'll show you shortly. But one of the things that came out most recently was the differences in the people who actually did convert while on cabotegravir, and they had lower incidence, as you see here. But there were 4 incident infections despite having target plasma levels. So even though these patients were taking medications and even though they had adequate drug, there were 4 infections. These infections also were associated with a delay in the detection, and because there was initially viral suppression and then a slow rise to that viral activity so that it could be measured. And so it was a different way to diagnose it than we're used to seeing breakthroughs in PrEP. And this idea of this viremic escape in the presence of cabotegravir is interesting and novel and new here. And this isn't seen in anybody who had a tail infection, in other words, people who stopped the regimen and still had lingering effects of long-acting injectable and then got an infection despite those lingering effects. This was different. These were in people who had fully active drug levels on board at the time of the infection. And so this, as uncommon as that was, and it was much less common in this arm than in the tenofovir FTC arm, it's important for us to remember that as we think about measuring that. When we look at the number of infections, there were 39 infections in the TDF FTC arm, and only 13 infections in the cabotegravir arm. And in fact, when you look at the infections in the cabotegravir arm, 2 of them were prior to infection. 3 of them were in a prolonged hiatus after cabotegravir. 3 were in the lead-in during the oral lead-on, and 5 of the patients were infected while on the regimen, and I showed you 4. So my point is, you have way less common infections in cabotegravir than Truvada, which makes injectables truly promising, but there are some wrinkles to using it, and we have to be sensitive to how we're going to diagnose those people when we see them. When you look at the role of adherence, you can see that in the group that was on the oral regimen, there were gaps in adherence. And these gaps were seen in drug levels that we would hope would be protective, and only in about 60%. And there's different analyses of this group amongst different populations, ranging from geographic region, from the race, age, and gender identification. And the point is, there are heterogeneities in this group of people who take Truvada, and the adherence is not perfect. In fact, of the people who are taking enough to be effective, you see that on average, it's only about 70%. That is the reason that the injectables were more effective, we think, that these breakthrough infections in the Truvada arm came in the group that had lower drug levels reflected by the lower adherence. The injection site reactions associated with the use of injections was, for the most part, modest and acceptable. Only about 2.2% of the people who got the injections had to discontinue because of an AE. And clearly, when you got those kind of reactions, that is what led to discontinuation. So injectables have great promise, but they also have some small amount of cost that has to be dealt with as we talk to patients and help them work through what that's going to be. And these were some of the adverse event rates. You can see that for the most part, they were well accepted. You didn't have any creatinine. You had less decreases in creatinine clearance in the group on cabotegravir than on the Truvada group. You had a little bit more nasopharyngitis for some reason that we're not sure. And you also had a slight increase in blood glucose, as well as pyrexia in the injection arm. So there are some differences in the adverse event rates, all to be taken care of as we watch patients on these regimens and track them. And finally, when we look at the issues of weight, there were some differences. Cabotegravir, over the course of about 2 years, had about a 1.48 kilo gain. Placebo was 1.57, and the Truvada had a lower arm. So there is some gain some weight gain associated with this, but I think most people would say over a period of that kind of time, in this case, 41 weeks, where you saw that 1.48 kilo gain, that would be something that is understandable and addressable between the patient and the provider. When you looked out further after 40 weeks, you had a leveling off of that. And so when you compare the TDF arm to the cabotegravir arm, they were not statistically significant. I'd like to move on now to some other agents. I think that cabotegravir is the first injectable that will be available. I think that in the European Union, it is, if not available now, it will soon be available. But there are other things to come, and I'd like to discuss two different ones. The first is lenacapavir, which is a capsid inhibitor. The capsid inhibitors have multiple sites of action related to capsid disassembly as well as capsid assembly. And it inhibits these multiple processes necessary for viral replication, which is the rationale behind some of the great potency we've seen with this. When you look at various dosing regimens, you can see viral load drops down to almost 2 logs, suggesting that this truly is a very potent regimen. And when we look at the PK, you can see that in oral PK and in subcutaneous regimens, this drug is attaining levels that are above the IQ necessary for inhibition up to 24 weeks. And so this gives us the ability to look at lenacapavir as a twice yearly subcutaneous injection preceded by an oral lead-in. This is an advance, potentially, in injectables. In cabotegravir, we showed monthly injections. Now we're talking about subcutaneous injections, much different than the gluteal injections of cabotegravir. Number two, the injections with lenacapavir could potentially be done by the patient rather than a different person who's not the patient, which is necessitated by the location of the injections with cabotegravir. So these are two advantages, as well as the longer duration between administrations. A second alternative to cabotegravir is islatravir. Islatravir is a novel NRTTI with two different mechanisms. It's both a mechanism of translocation and delayed chain termination. This combination of these two locations also gives it a very potency and is responsible for both its use in treatment as well as its use in PrEP. When you look at the log drop here, again, you get down to close to 2 log drops with these agents, and you can see a single oral dose as low as 0.5 milligrams had continued suppression of HIV for greater than 7 days. This has given us a rationale for using islatravir in PrEP. When you look at the adverse event profile, the drug is well tolerated. It's not been difficult to take as in studies where we've looked at it in oral administration along with doravirine. So we know that the drug is well tolerated, and the use of PrEP is very exciting. Weight change, you have very low level changes, so the same kind of issues that we looked at before with cabotegravir. It's well tolerated. And the issue for PrEP is relevant because we know that it stays up for a long period of time, and it stays suppressed. And we know that in post-exposure situations, it could be used almost for a weekly regimen. And it's felt that for PrEP, it could be used monthly, perhaps, or even longer. And so here's looking at data, looking at a implant, and whether this will eventually be used in implants or subcutaneous injections is the subject of ongoing current investigation. But you can see with these, you're able to keep levels up above the level in order to establish prevention of upwards of 4 months and perhaps longer. And so these dosing strategies with both islatravir and lenacapavir offer us potentially longer frequency between doses of administration compared to cabotegravir. Finally, the last group of injections would be broadly neutralizing antibodies. This is a different class entirely that works via an immunologic mechanism. The exact interval between dosing frequency here is still being determined, but this gives us a third alternative in the emergence of injections. In general, these approaches really will provide patients with more choices for HIV prevention. And with the idea of more choices, we think that we'll achieve more engagement and greater success. Thank you for your time today.